Today's presentation is about the approach towards bloating in the clinical services. So in this, actually this is a picture just illustrating the CVSKL. I think as you are aware that, at the moment CVSKL will have a positive COVID case, and so far we're still dealing with the crisis, but so far, the condition is only contained in the high dependency and ICU. So all the staff everyone here in CVSK are all okay and fine. So without further ado, I'm going to proceed with my presentation, which is the approach toward bloatings in general practices. We know that bloating and abdominal distensions is a very common scenario in our practice. As illustrated here, this is a female bodybuilder, and she's basically shows her progressions of her tummy over across the day. Early in the morning when she's woke up, actually her tummy is flat. But as you can see from the noontime and towards the evening, you can see that her tummy is getting more and more bloated. This happens usually after she consumes her meal. And what she used, she used a FODMAP diet to get herself cured from this abdominal distension and bloating. And so what do we know about the gases in our gastrointestinal system? So first of all, we need to understand that most of the gas from our gastrointestinal tract are swallowed or consumed when we are eating or drinking water. And most of the gases that is being swallowed into our digestive tract actually are the nitrogens and the oxygens. And as the food passages into our stomach and our small intestine, there is some carbon dioxide being produced. And besides that, apart from that, those nitrogens that's been absorbed into the lung, some of the nitrogens will be diffused slowly into the gastrointestinal tract, either the small bowel or the large intestine. And as the food reaches into the large bowel, there will be fermentations of the fibers, and thus there will be carbon dioxide and hydrogen gases produced. As the food passes along the large bowel, then the methane gas has been produced. Something maybe we should talk about the methane gas is methane gas actually it causes, when it's present in an abundant amount, actually it slows down our digestive tract, and thus it can cause us constipations. So today's lecture is about talking about bloating. How do we perceive about bloating and the causes of bloating? And in the practices as a general practitioners and a gastroenterologist, so we need to know what to investigate and the decision on when to refer and how to further manage our patients. First of all, we're going to start with definitions of bloating. Actually, we know that bloating is a very common symptoms of patients with functional digestive tract disorders. And up to 1/3 of the population may complain of bloating. So what is bloating basically? Bloating basically is a sensation of increased abdominal pressures with or without visible abdominal distensions. And we need to understand that bloating basically is a subjective sensations, and abdominal distension is the objective assessment of the bloated sensations. As illustrated in this picture here, you can see that when the patients complain of bloating, some of them actually may not have any abdominal distensions at all. They just feel that their abdominal cavity is full. For those patients who have distension, then they can sense that actually there is a tightness of their pants towards the end of the day. And some of the patients may have both bloating and distensions as well. So in conclusion, both of them are related, but a bit different symptoms. And during my clinical practice, I eventually found that bloating and distension is quite very challenging to treat. And there is one study that looked into the Army veterans' prevalence of bloating in the Army veterans. Actually, they found that the prevalence is around 21%, and around 2/3 of these Army veterans actually are also having irritable bowel syndromes. So bloating actually is a very common symptom in patients with irritable bowel disease. And however, they also noticed that maybe around less than 50% of patients who may have dyspepsia or functional dyspepsia may also have bloatings as well. And those patients who have just functional bloating alone is less than 10%. And if you read around wrong floor criteria, there is one entity called functional abdominal bloating or distensions. This group of patients, they do not fulfill the diagnosis for irritable bowel syndrome, functional constipation, functional diarrhea, or postprandial distress syndromes. Basically, all these group of patients, they have a recurrent bloating or abdominal distensions at least once a week, okay? At least once a week. And bloating should be the only predominant symptoms compared to other symptoms. So when we come to about the causes of bloating, actually there is a lot of causes, and all these causes may be organic or occasionally maybe just be functional. And the organic causes, actually there's a lot. It can be due to infections, inflammations, bowel ischemia, autoimmune diseases, malabsorptive diseases, or cancerous etiologies. When all these etiologies, all these organic causes has been ruled out, then functional causes is the only explanation. So when we look into the causes of bloating, first of all, we need to touch about malabsorptions. So malabsorption in Malaysia actually nowadays is quite uncommon already. I think in our previous, when we study as undergraduate students, we always read about celiac disease. But the other entity, I think, which is more common than celiac disease is pancreatic insufficiency. I mean, especially in our patient who has chronic alcoholism. And other causes that we need to consider is these motility disorders, which usually is due to diabetes mellitus or hypothyroidism or scleroderma disease. However, I think some of the patients may have some medications that can cause bloatings as well or constipations. Surgical interventions, things like frontal plications, gastric banding surgeries, these are other things that we need to consider. And not forgetting here, which is the adhesion collate, sometimes may also associated with bloating. Infections, parasitic infections, or small intestinal bacterial overgrowth, these are the other causes that may potentially cause bloatings as well. And I think you do aware that some of the patients who presented with acute gastroenteritis, they may also complain of bloating as the symptoms. And the most importantly is the malignancy, which we can't afford to really miss out, which may be due to gastrointestinal tract diseases, ovarian origin, or ascites, or peritoneal metastasis. And other physiological condition that we may need to consider actually is basically the patient is just being fat, or because the patient is pregnant. Just now I mentioned about celiac disease, but in our clinical practice, do we need to consider celiac disease? Actually, I would think that this is quite difficult. There is one local study that looked into the seroprevalence of anti-tissue transglutaminase IgA in Malaysia populations. They found that actually the seroprevalence actually is around 1%. However, in this study actually is conducted in University of Malaya. Unfortunately, in this study, they managed to find 6 patients who has seropositivity towards celiac disease. However, none of these group of patients, they have any gastrointestinal symptoms, and there is no further evaluation with the endoscopy biopsy at the duodenum. So generally, do we need to consider about celiac disease? I think maybe we need to look into the patient's profile. So in the patients, they have a low celiac disease probability, meaning that they have no malabsorptive dysfunctions, meaning that if the blood test doesn't show any anemia or there's no B12 folate deficiency, I do not think that we need to consider about celiac disease. Of course, family history of celiac disease is very uncommon in this part of the world. And being Chinese myself, and of course, it's very unlikely. Thus, if you really need to consider to investigate about celiac disease, maybe you just proceed with IgA, tissue transglutaminase. That will be more than sufficient already. Or do not need to investigate if the patient doesn't show any features of malabsorptions. So now we come to the mechanisms of functional bloating. So basically, there's 3 theories behind about causes or sensations of bloating. First, actually, is the increase in the abdominal wall tension. So when we talk about abdominal wall tension, it can be due to the gastric or the intestinal expansion by swallowed air or carbon dioxide. So in your history taking, you need to ask about your patients whether they like to take alcoholic beverages or any carbonated beverages. In fact, frequent usage of chewing gum itself also may cause a frequent swallowing of air into the stomach and gastrointestinal tract. And of course, we need to remember that food is the potential cause of the bloating. Of course, gut dysbiosis is one of the things that we need to consider also. And when you consume a lot of osmotically active food products into the bowel, it causes more retentions of water. That also causes bloated sensations. Constipation itself is a very important cause of bloating that we always need to look into, because most of the time, if you have a patient with bloating and abdominal distensions, most of these patients, they do have constipations. Second causes of abdominal bloating is just heightened sensations of abdominal wall distensions. This may be due to the abdominal wall inflammations from various causes of colitis or enterocolitis. Sometimes it just may be due to the hypervigilance on the patient's part. They have a heightened sensations of bloating. And we need to understand that some of the patients with bloatedness, actually, they may do have some sort of neurosis of background psychosomatic diseases that may make them to have all these sort of bloated sensations. Of course, the patient's menstrual cycles, if they take frequent fatty meals, this also potentially cause more bloatings as well. And since in the early 2010 or late 2000s, actually this is another theories that come about on, will give rise more understanding about why the patients complain of bloating. This is because most of the time, if we look at this picture here, when you have functional bloating, most of the time is because of there is diaphragmatic wall contractions and abdominal wall and the anterior displacements of the anterior abdominal wall. So this causes more bloated sensations. And further on with this illustrated in this diagram here, in the normal patients, when you have more gases produced inside the abdominal cavity, there will be a relaxations of diaphragmatic muscles. So meaning that there is a displacement of our diaphragm towards a thoracic cavity. And this is also followed by the subconscious anterior abdominal contractions. So if you look at the normal patient here, actually there is not much of visible anterior abdominal wall distensions or distensions of the abdominal wall cavity. Whereas in a patient who has a functional bloating, despite minimal air insufficiency, they will still have a dramatic contractions of the diaphragmatic wall and relaxations of their anterior abdominal wall. And this actually causes bloating and distensions. So these three theories is very important in our further management of patients with bloating. So first of all, we need to touch about history and examinations. So we understand that bloating is a predominant complaint, but we need to time the bloatedness. We need to know that whether the patient is a stomach bloater or the gastrointestinal or the large bowel or small intestinal bloaters. And we need to understand the patient's comorbidity, medications taken, supplements, and their dietary habit. Of course, as I mentioned earlier, the timing of symptoms in relation to the food is very important. And in terms of food, we need to ask about what is the size and what's the frequency of the meal. And do they take all these sort of fructose, lactose, or any gluten products, which may cause a more windy situation for the patients. And what's their dietary habits as well? Do they always eat their food very fast, or they always talk when they are eating? Because all these two maneuver causes more swallowing of air into the stomach. Okay. As I mentioned earlier on, the carbonated drinks or caffeinated drinks and the frequent chewing gums as well. So what are the medications of supplements that can cause bloatedness? There are opium. Ficillin actually is a common product that we use for constipations. Iron tablets, metformin, magnesium, laxative, and antidiarrheal agents. These are the things that we may need to ask about. Any medical comorbidities, especially paying attention towards any small intestinal and bacterial overgrowth, things like prior abdominal surgeries, aerophagia, and these sort of patients, they may have frequent belches also. And for the history also, for this group of patients with aerophagia, those are the patients who uses chronic CPAP at night, especially because all these sort of patients who has usage of CPAP, they may have a higher tendency of air swallowing. Things like systemic sclerosis, Crohn's disease, stricture, dysmotility, acrohygiene, all these are other factors that we need to consider. When you talk about gastrointestinal symptoms, we need to emphasize on alarming symptoms, whether they have a nocturnal abdominal pain, weight loss, hematochezia, any systemic symptoms like loss of weight, loss of appetite, or fever. Diarrhea or sectorias are something that we always need to ask about the patients, and whether there's any features or obstructions, especially like vomiting. And of course, a change in the bowel habit in the patients who is more than 50 years old is very important, and any underlying family history of malignancies. On physical examinations, apart from the medical comorbidities that we need to look into, when you look into the abdominal examinations, we may need to examine whether the patients have a flabby abdomen, because the patients have a very amuscular, or maybe I'll say the amuscular abdominal wall. I mean, their tendency towards bloating actually is higher. Of course, during the abdominal examinations, we're looking for things like organomegaly, abdominal tenderness, surgical scars, palpable masses. Of course, rarely we may have patient who has a positive circassian splash sign. The reason being that we need to do proper digital rectal examinations are to evaluate patients for evacuative disorders such as anal dyssynergia. So after the detailed history taking and physical examination, so we need to divide our patient into four categories, whether they have bloating with diarrhea, or bloating with constipations, bloating with mechanical disturbances, or bloating without mechanical disturbances. Because this is very important to divide the patient into these four categories to assist us in further investigations and management. In general practices, I think you can request for a general basic blood test, abdominal X-ray, ultrasound abdomen. Viral hepatitis, if you're thinking of ascites. So the other thing maybe I need to touch about is tumor markers, because sometimes our clinical practice we like to use clinical tumor markers. But maybe one advice about the usage of clinical tumor marker is when you decide to use clinical tumor markers, you better do a full panel of tumor markers. Because I do have recent history of one elderly Chinese lady who came to see me because of abdominal distension. Physical examination actually basically shows that she has a bit of a shifting downwards, and abdomen basically is a very doughy sensation. It's not typical of ascites as well. She already have a list of limited tumor markers that performed by her general practitioner. I think it's just CEA and alpha-fetoprotein, which unfortunately came back as negative. Subsequently, I requested a full panel. Actually, this patient has a metastatic pancreatic cancer, which has already spread to the peritoneal cavities already. Celiac serology, I don't think we need to think about it. Of course, a CT scan, gastric antigen test, endoscopy procedures. This is when the patient has been referred to a gastroenterologist, whether they need to perform all these tests. I think management of patients, if we have basically ruled out most of the things, we can fairly reassure the patients that they are well, and most likely this is just a functional etiology. So we can recommend the patients to do diaphragmatic breathing or abdominal feedback, which later I'm going to touch about. Of course, dietary and meal advice, we always ask the patient to try to take a small regular meals, avoid trigger food, because in the history, we always ask the patients whether there's any particular food that can trigger the symptoms. Of course, we being Asians, we may need to consider to limit our lactose consumptions, because everyone has their different thresholds towards lactase. Because after a certain amount of lactose consumptions, then only we may develop bloating, very windy abdomen as well. And of course, diet intervention, which we're going to touch later on, is the low FODMAP diet. And a lot of studies shows that weight loss and exercise also helps in terms of management of bloating. And symptomatic medical therapies, sometimes, especially things like meteospasmia, is very helpful, because medial albumin actually it help address in terms of bloating and also in abdominal spasm. If the patient has a bloatedness associated with the abdominal pain, colicky abdominal pain, then you may can consider usage of Buscopan. Probiotics, prebiotics actually also helps. So these are the things that we commonly use in our clinical practice. And of course, management of constipations on evacuative disorders is very important also. So maybe I'll talk about breathing exercise. Of course, before about breathing exercise, there's something called abdominal biofeedback. If you read some literature, basically, abdominal biofeedback actually is not available in Malaysia. Basically, this type of therapy, they use electromyography, which hook some electrodes on the patient's thoracic wall and abdominal cavity, just to look into their activities and try to make the synchronized movement. Basically, you understand that we need to train the patient so that every time when they have a perceived bloatedness, there will be a reduced diaphragmatic contractions or the anterior abdominal wall relaxations. So since we do not have abdominal biofeedback therapy, so what is the next best treatment? Actually, the next best treatment actually is the usage of abdominal breathing. So how to use abdominal breathing? So basically, what I do in my clinic is I always ask the patient to sit down in their standing position. Then actually I will ask them to put their hand on the chest and abdomen. Before I begin my instruction, I will ask them to breathe a few times for me to see how they. Just to divide them into whether they are chest breather or abdominal breather. So until now in my clinic, actually, I never see any abdominal breather at all. So most of my patients, actually, they are chest breather, meaning that when they put their both hands on their chest and abdomen, so basically most of the time they will have a movement of their hand on the chest, which is illustrated here. And so you can demonstrate by Amir here. Amir actually has more movement on the hand, on the chest, rather than the hand on the tummy. So we need to teach our patients actually to lean on the back and then slowly try to breathe to make sure that the hand on the tummy is moving like this. Okay, so like illustrated in the Amir here. So the tummy is moving, tummy hand is moving, not the hand on the chest. So we need to teach our patients to do this. And how frequent we need to do this is maybe just twice in a day or up to 3 times, just to do a few reps so that they can train themselves on how to breathe properly. So the other way you can tell them is ask them to breathe by practicing yoga breathings. So Ms. Lin is going to talk more about this format. Actually, formats are the short form for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Basically, this is just a compilations of a lot of theories that derived since 1965 and come out with this format theory. Basically, what is the theory behind the format is when you take a lot of food that has a lot of format inside your digestive tract, it causes a more osmotic load in the small bowel, causes small bowel distensions. And in terms of a large bowel, it causes changes in the gut. It causes a gut dysbiosis. And it does, and when these food products being fermented by the bacteria, it causes more gas productions and a lot of inflammations at our large bowel and causes heightened sensations of bloatedness. And a lot of studies shows that low ferment diet basically helps in terms of symptoms of abdominal bloating, abdominal pain, and weighing as well. And whether there's any experience of format in Malaysia. So actually, Dr. Wong herself had published an article about the usage of format in University Malaya. Unfortunately, about in this study is that the compliance towards format diet actually is very poor. Only around 50% of the patients practice format by the end of the study. But however, they do found that actually the use of format actually does improve a lot of abdominal pain and abdominal bloatedness. So what are the other methods that we can use? So antibiotics, I think all of you is not unfamiliar with the usage of antibiotics. I think all of you may have used Fragiles and Celiac in the patients with bloating. So in my clinical practice, actually, I don't use antibiotic for bloating. The only antibiotic that I use actually is rifaximin. And of late, there's a lot of studies that shows that demonstrated that actually rifaximin actually is a good antibiotic for use in a patient with irritable bowel syndrome and a patient with bloating. And then the other question is, can we repeatedly use rifaximin in the treatments of IBS or bloating? Actually, for me, up to this moment, I do not reuse rifaximin because some of my patients, they are a bit resistant in repeating usage of rifaximin. But I do have colleagues who has frequent abdominal bloating and irritable bowel syndrome, and he uses his rifaximin a lot, a few times a year. So far, it seems to be working for him. And this is a study that is basically which illustrate the repeated use of rifaximin. It seems to be that with the repeated use of 2-week course of rifaximin, it seems to be still beneficial in the patients. Of course, with the long-term antibiotic usage, well, we worry about resistance rate increase. Other things that we need to talk about is the relief of constipation. So in our practice, we use a lot of medicine to relieve the constipations, but just a special attention here, because if you want to treat constipation in a patient with bloating, you do not try to use non-fermentable and non-bulk forming laxative, meaning that you try not to use lactulose or dufilate, because dufilate is a non-acceptable a type of non-acceptable fiber. It may cause some more bloating symptoms. So if you use things like fibers as well, so usage of fiber also in the beginning, it also may cause some more bloating. So I tend to use more of folates because actually I do found that patient of mine that using the folates, they do have reported less bloating probability. So other medications that are used in terms of bloating and constipations are such as Risolol, just a very short course durations. Special attention regarding on bisulfonyl or Dalcolax is so you may need to pay more attention on abdominal pain, because a patient who has underlying abdominal pain with constipations, you may try not to use too much of bisulfonyl because it causes more abdominal pains. And of course, we can consider the use of other constipation agents. Special attentions with probiotics or prebiotic. I'm not a very strong believer, but I do encourage my patients to try with probiotics. Usually, I ask them try to look for bifidobacteria, because a lot of studies shows that bifidobacteria actually is more beneficial for the patients with irritable bowel syndromes or bloating. However, that one thing to consider is not all probiotics demonstrate a similar benefit. So I always ask the patients to try around, and I myself, I do not prescribe. I basically ask them to go out and buy their own probiotics, because patient likes to try with their own probiotics. So study has shows that when they compare probiotics and low FODMAP diet, actually they found that actually patients who's on a probiotic group has more sustained relief in terms of their irritable bowel syndrome. In terms of usage of neuromodulators, things like TCA, SSRI, actually most of the time I will try to look for underlying anxiety disorders or any major depressive disorders. In the patient that do have, I will encourage my patient to see psychologists or psychiatrists. I do not prescribe all these sort of medication myself, because I prefer the patient to see a psychiatrist to see whether there's any underlying psychiatric disorders. So in conclusions, this is a very important slide. So basically, I just run through the management of bloating. So if you have a patient who has a chronic complaint of bloating, abdominal distensions, first is to look for warning signs or symptoms. If there is, try to manage accordingly. If the patient do not have any bloating, any red flag signs, then you need to look into whether there's any altered bowel habits in terms of constipations or diarrhea. or constipations or diarrhea, and then manage them subsequently. And if the patients do not have these outer bowel habits, then you may need to consider to things like FODMAPs, see whether there's any symptoms improvement. And the other things about the, then we may need to consider diaphragmatic breathing, which is the visceral somatic reflex or visceral hypersensitivity, and then try to manage accordingly. The other thing here, this is HBD, which is actually is the hydrogen breath test. This is not available in Malaysia. So hydrogen breath test, basically, we are use it for the diagnosis of a small intestinal bacterial overgrowth. So, but normally I don't investigate. I just try with rifaximin. So again, detailed clinical history, including alarming symptoms, detailed dietary history, physical examination, including digital rectal examination, which is not commonly done nowadays. When I say about digital rectal examination, it's a very detailed digital rectal examination, not just putting your finger into the patient's anus and try to feel for their whether there's any LAS, and try to minimize your investigations. With that, I thank you for your attention.